Dr. Edward.
I welcome next speaker, Dr. Giridharan, to speak on the topic perioperative concerns in a renal transplant recipient. Dr. Giridharan is a chief civil surgeon. He's working at Stanley Medical College, studied at Stanley Medical College. He's a consultant anesthesiologist. He has done both his undergraduation and post-graduation at Stanley Medical College. He has 24 years of experience. He has specialty of practice of renal transplant, trauma and orthopedics and cosmetic surgery with a teaching experience of 17 years, and he has presented topics in various CMEs, workshops, state and south conference. He has chaired an ISA PG Assembly State and National Conference. He is a former Chennai City ISA Treasurer and currently Tamil Nadu ISA Treasurer. So over to you.
I thank, good afternoon one and all. I thank the organizing team of ISA Mysore and Karnataka for giving me this opportunity. And my topic is perioperative concerns in renal transplant recipient patients. So first, before going that, what is chronic renal disease? Chronic renal disease is disease presents as the kidney damage, which is estimated by the glomerular filtration rate less than 60 ml per minute in 1.73 square meter for the past 3 months. And after, this gradually increases, and if the GFR goes below 15 to 29 ml per minute, they land up in end-stage renal disease. The function permanently decreases, leading on to the need of the regular cause and the long-term dialysis or by a kidney transplant in maintain the normal life. So before going to the topic, let's know what the history starts about. The renal transplant was started in the 19th century, and various studies and surgeries were performed till 1954 without any success. In 1954, Birmingham Hospital, Boston, they operated on a twin for a renal transplant, and the patient survived for 10 days and they lost the kidney. And gradually within a year they lost the patient. And then the first transplant in India in 1965, King Edward Hospital, Bombay, and where the transplant is done and the patient survived for 2 years. So the problem is this: in due course of time, when we take the statistics in the last 1 year, after the COVID of 2 years, during the COVID there were a lot of failures, whereas in the last 1 year the failure rate is around 10 to 15% in a transplant all over the world. So the reason for this is because of the development of understanding of the renal problem by the anesthesiologist and by the nephrologist, and the newer drugs which is being used for the anesthesia and post-op care are the reason for the development. So what our topic is perioperative. Perioperative means it is pre-operative preparation, intraoperative management and post-operative. So this has been defined and classified as pre-transplantation phases, where the patient enters the hospital and the patient is prepared for the surgery. And the transplantation and operation phase is that right from induction till extubation. And post-transplantation phase is the 10 days after the surgery, where the patient is getting observed and maintained and discharged. So the etiology, one of the common causes is diabetic and hypertension, which is more than around 40 to 45% of the problem. And glomerular nephritis is 23, polycystic kidney 6, chronic pyelonephritis 5%, obstructive, autoimmune disorder unknown causes. The reason for knowing the etiology is very simple. It is a long-standing disease which lead on to the renal transplant. The acceptant transplant is better, whereas if there is autoimmune bodies present in the patient in autonomic disorders, then the acceptance is going to be problematic. This was the myth theory which was kept prior. Now, because of the development of plasmapheresis and immunosuppressants, this has changed a lot. So classification of CKD, you can classify into various stages like stage 5. Our significance is less than 15 is the end-stage renal disease, which the patient has been with or without urine output. One is non-oliguric, non-concentrating renal failure, where it fails to concentrate the urine, only water is eliminated. And second thing is oliguric or anuric phase of patients, which the solute as well as water is not eliminated. So the various pathophysiology, as Dr. Edward sir has already mentioned about the pathophysiology, the CVS, the main volume overload and the resistance of the renal will cause hypertension, cardiac failure, uremic pericarditis, whereas in the respiratory system, the volume overload develops pulmonary edema, and because of the interstitial volume distribution, pleural effusion differs, and because of immunosuppression, the infection occurs. In gastric, delayed gastric emptying time, And malnutrition is the principal because of non-absorption and loss of appetite. In nervous system, neuropathy and uremic encephalopathy are the features. In the renal, because of the fluid and electrolyte imbalance, the acidotic state of the patient is developed. Whereas in hematological, they develop chronic anemia due to suppression and coagulopathy. In immunological, the immunosuppression occurs because of the response and the acidosis, and the immune response significantly decrease in the patients. Let's see the signs and symptoms. The gradual decrease in the urine output will increase the volume, which causes pedal edema, which will substantiate increase to generalized edema and causes facial edema of the face. And the gradual increase in hypertension, already existing hypertension patient going for renal failure will go for uncontrolled hypertension, whereas the patient who was normal in hypertension, normal in pressures, developing renal will develop hypertension gradually. The importance is how you monitor or how you control the hypertension, whereas how to maintain the pressures after the graft is been functioning. So other this loss of appetite, nausea, vomiting, uremic pruritus, breathlessness, GI bleed, and insomnia. So right, we go into the medical management, then go for the transplant. So our medical management is as due to volume overload, strain on the heart, reduce the physical activity, restrict the fluid intake. The fluid intake is the urine output plus 750 ml is the criteria, where the patient is throwing normal urine, there is no restriction of fluid, the patient is not passing urine, then automatically you can keep a restriction of around 1000 ml. Then you can restrict salt, not avoidance of salt, restrict salt, that is 2 to 3 grams per day. And restricted diet means you have not to put the pressure on the existing kidney. So this means that your protein status should be kept around 0.6 to 0.7 grams per day, per kg per day. And other important thing, what are the comorbid diabetes? Usually diabetes settles out due to dialysis or with renal disease is being under control, and comorbid illness should be treated appropriately to avoid the sequel of the disease. So then renal replacement therapy. Renal replacement therapy is how you eliminate the water and how you eliminate the solutes. This is done by mainly peritoneal dialysis, where the patients are not fit for hemodialysis, not hemodynamically stable, where your peritoneal indwelling catheter is placed into the abdomen, either local or under anesthesia, and they are used as and a solution is passed into the abdomen at least 4 to 5 cycles, a period of 6 to 8 hours, and this is mainly done by the osmotic diuresis and the solute diffusion. The next is common is going to be hemodialysis, where the blood is withdrawn from the body, it is circulated into the hemodialysis machine, where the similar osmosis and the filtrate is occurred, and the blood is being recirculated. This, when there is an emergency, when the patient suddenly land up in failure, we are going for an emergency hemodialysis by doing a HT catheter into a major vein like IJV or subclavian, or a planned technique of doing an AV fistula, which gets organized in a period of 6 to 8 weeks, which can be used as an elective hemodialysis. Then comes the renal transplantation, where you keep a kidney from a donor into the patient, and all these statistics are being improved day by day. So types of renal transplant, we should know what types of renal, that is living donor. In the living donor, it is blood related, like father donating son or son donating sister, son donating mother, whatever may be, it's a blood related. And other is going to be an emotional grounds, which is a female, which is an emotional grounds based thing. And third is going to be an unrelated donors. And all this is important because related, they have a good cross match, whereas others varies according to the circumstances and situations. Then now comes the recent concept is organ harvesting or the deceased or cadaveric donation, where we do in 2 types. One is beating heart, which is nothing but the brain dead patient which is functioning. And second thing is non-beating heart, where the patient has accepted for organ donation. Immediately after death, till the circulation stops, you can even retrieve the organ. Here the difference between the two is you harvest all the organs like liver, renal, and then go for heart and lung. Whereas in a non-beating heart, the heart and lung is removed first, then gradually goes to the pancreas, liver, and then the renal. So what is the absolute contraindication? Initially it was 5 years of lifespan. Now because of the quality and the life expectancy, it has come to less than 2 years in a predicted graft loss of greater than 1% in less than a year. That means if a patient is coming for a second or a third transplant, already the existing transplant lifespan is going to be important. If it is less than a year, these patients indigenous not accepting a transplanted kidney, so try to avoid the transplant. Unable to complement with the immunocompromised related and threatening complication where the immunity is very low level when the total count is always less than 2000. So relative contraindication, where the contraindication can be improved or corrected and do a transplant. Age more than 70 years. I had an experience once I rejected a transplant for a patient of 70 years. He said me, my lifestyle is better than your lifestyle. He walks 5 kilometers a day, so never go by age is the recent principle. And even medico-legally, the case will not stand. Patients can get transplanted at any age. And according to the infection can be treated and taken up. Tuberculosis, where the tuberculosis is treated within 6 to 8 weeks, and then transplant is done. And any liver disease which is correctable, or when they go for an uncompensated, they are not fit. So in case of cardiac condition like severe diffuse atherosclerosis, where you see the renal vessels which are good, then proceed. If the renal vessels are compromised, then it is decided by the vascular people. And cardiac dysfunction is less than 20% in any status, that is, usually global hypokinesia occurs between 20 to 30% is accepted, whereas if the cause of global hypokinesia is due to cardiac perfusion, then these patients are not indicated for surgery. And psychological disturbance and other things are relative, and body mass index is greater than 35, ask the patient to decrease the weight, then come for surgery. Then evaluation is so important that the duration of the kidney disease is important. How it progresses, how it lands up, how the patient has gone for dialysis, frequency of dialysis, duration of dialysis, weight loss of dialysis, and how compromised status of the patient between the dialysis period. So, and also the control of the morbidity disease. So investigations, complete blood count. Here 2 things is important. One is the anemia. Then anemia, second thing is going to be decreased platelet count. In renal function test, urea creatinine value. So creatinine decreases when the renal function is lost by 75 to 80%, and only when the patient is having elevated creatinine, then the patient are renal compromised. Liver function test is appropriated hypoproteinemia. Coagulation profile is altered. Here calcium decreases, phosphorus increases, and magnesium also increases. And the patient develops in an acidotic state. After COVID, CT chest is must for organizing and assessing of the respiratory status. ECG, where hypertension, left ventricular hypertrophy, and volume overload can be seen. Echo, where there is 2 important things. One is global hypokinesia. Second is going to be pulmonary hypertension. When the patient is on a compromised state, like cardiac and old age, coronary angio is must to make rule out that the cardiac is doing good, which can cope up the kidney after the transplant. The 2 important things is the kidney is maintained on 2 things. One is going to be the pressure of the patient, as it is a denervated kidney. The second is going to be the volume. If the cardiac is not compromised, then it's fine. If the cardiac is compromised, then it is difficult. When given the option whether the kidney or the heart, everyone will go for a heart compromising on the kidney. So one thing I want to say about the Holter monitor. This is more important because uncontrolled hypertension, arrhythmias, where you do 24 hours Holter ECG and BP monitors so that your pressure is maintained between the criteria of the systolic and diastolic pressures. This is more seen in the patient like PH going for renal failure, where the diastolic and the systolic pressure is too high to be controlled. So the recipient preparation, pre-op night sedation, anti-anxiety drugs, alprazolam is used, proton pump blockers, and antiemetics. Fasting, gastroparesis is the reason, 6 to 8 hours, and dialysis before surgery is important. That will I deal in a few slides later. The blood sugar and serum potassium. Even though the stress, they can have hyperglycemia. So 1 hour before the surgery, you do blood sugar, and serum potassium is to maintain less than 5.5 during the surgeries to avoid arrhythmia. And the pre-op immunosuppression is a topic of discussion, will be in the future. Then the consent. Consent is so important as you are dealing with 2 patients, taking a kidney from 1 patient and giving. So that's a vital organ which is going to be kept in importance in your mind, and the consent is very important as a medical legal aspect. So immunosuppression, because now initially it was ABO incompatibility, now any patient can donate kidney to any person. That has become the concept of advancement. Here where you suppress the immunostatus and accept the kidney. As it is a denervated kidney, this is one of the possibility. Here immunosuppression is in 3 principles. One is the first phase. First phase of immunosuppression is treated just before the surgery or during the surgery or the first 1 week of surgery. Because when there is a compromised or decreased urine output, or if the creatinine doesn't settle within 24 hours to a significant level, then the patient may go for a immunocompromised status to suppress the kidney for a better outcome. The second phase is continuing of the drugs orally for a period of 3 to 6 months, where you keep the serum level monitored, and you should not develop the immunosuppressive drug toxicity also. The third phase is it is accepted as a lifelong immunosuppression therapy. But in advanced things, what they say is if the kidney is accepted for 5 years in a body, then the lifespan is going to be longevity. So immunosuppression is now indicated for 5 years. And these are the drugs for the immunosuppression. And in the pre-op hemodialysis, you do it 12 to 24 hours prior to the surgery, where to optimize the patient with fluid and decrease the potassium value and the residual anticoagulation. The pre-medication is routine like anti-anxiety drugs pre-night, then anti-secretory agent glycopyrrolate is unaltered in the CKD patients. H2 blocker are avoided in renal compromised patients or renal disease patients. Midazolam can be used. Metoclopramide also used for increasing the forward motility. So vascular access, IV line on the other side of the AV fistula hand, and better have a wide bore needle, 18 gauge or a 16 gauge. And if there is a compromised status of the venal access due to various punctures or other things, you can go for a central catheter. But the central catheter is going to be taken if the patient is already on HT by an ultrasound guided. And nowadays they say source of infection is also be a criteria of the HT catheters. Monitoring, standard monitoring is kept. Invasive monitoring is going to be kept like arterial BP and CVP. Arterial BP in a cardiac compromised status or a cardiac compromised patient, and CVP to keep the pressure so that how you can maintain the volume status, core temperature and urine output after surgery. So induction, you can go for conventional agents, propofol, rapid sequence induction is due to your full stomach. Succinylcholine can be used if it is less than 5.5. In difficult airway, rocuronium can be used, and ideal drug is going to be atracurium and cisatracurium. So in induction drugs, you have to titrate the drug according to the volume of distribution and the free drug radical. This is compensated by increased volume and the free drug radical, because in thiopentone it is not altered. In propofol has to be increased in the dose due to the increase in the volume of the distribution. Ketamine intermediate has no change of distributions. So rapid sequence induction can be done, and patients can be fluctuant in BP. Either they have severe hypertension or hypotension. In case of uncontrolled, you go for drugs which can control the stress response of a laryngoscopy in intubation, like fentanyl, xylocort, and even you can use esmolol to attenuate the blunting response of the hemodynamics. Muscle relaxant already discussed. Succinylcholine, if the potassium is less than 5.5, ideal drug is cisatracurium. Maintenance anesthesia, oxygen and air, and the volatile is preferred is isoflurane and desflurane. If unavailable, you can use low doses of sevoflurane, and you can even use intravenous anesthetic agents like fentanyl with combination of propofol also. But your idea is to always have a good hemodynamics and a good control of your BP. And your BP should be higher during the status of your clamp release. Fluid management is little tricky. As the patient is dialysis, they will be in the low volume status, in hypolimic status. And if you use a CVP, you can keep the volume status around, you can keep the CVP around 12 to 15 and go even up to 18 to maintain a good perfusion of the kidney before the clamp release. And the drug of choice, the fluid of choice in crystalloid is normal saline. Don't trans too much of normal saline, which will cause hyperchloremic acidosis. Now they say you can even use balanced salt solution, and even ringer lactate can be used after 1 to 1.5 liters of normal saline, and if the potassium value is normal. All the colloids are preferred for optimizing the volume status, but they are not contraindicated. If at all you want to use colloid, then the colloid of choice is gelatin. So if there is a bleeding and other problems, if you want to give blood, try to avoid blood because of the problems of the transplanted kidney, whereas graft rejection can be a possibility because of your blood transfusion, whereas if it is required, you can go by RBC washed platelets, RBC washed blood. So the monitoring of the hemodynamics is by static macrocirculatory hemodynamic and by the dynamic hemodynamics. In static, it is MAP and CVP are monitored, whereas dynamic, these are the things to be monitored, which will be dealt by the next speaker. So then warm ischemia time, where the clamp is done, and then the perfusion of the kidneys by the cold ringer lactate or a special solution of the solution is used for the perfusion of the kidney for removing all the blood in the kidney. So this is the warm ischemia time from the clamping. Then cold ischemia time is the irrigation with the cold ringer lactate. Then again warm ischemia time starts during anastomosis, then the release of the clamp. The donor kidney is placed in the right iliac fossa, renal vein is anastomosed to the external iliac vein, artery with the external or internal ureter to the bladder. Once the clamp release, you develop a hypotension, which is been due to the unclamping status. You can either maintain by volume, and it can be recirculated in a critical patient, well hydrated renal function. It depends upon the renal perfusion. The CVP is to maintain high, and our idea is to maintain a good perfusion. Immediate urine output seen in 90% of the patients, whereas the decreased urine output during closure is due to the kinking of the vessels. So you should be more careful about that. Intraoperative problems, hypertension, hypovolume, acidosis, myocardial dysfunction, and release of the inflammatory response due to the clamping. Excessive bleeding is due to the coagulopathy, acidosis, and hypothermia, where I have already dealt how to treat that. Dopamine, initially even this have a low dose dopamine on renal, but there is no role of dopamine in renal transplant. The drug of choice is noradrenaline to maintain the BP. Loop diuretics, they said initially there was the role, now no role of loop diuretics. If the volume is there, you can give a low dose of diuretic just to enhance the urine output. Post-operative recovery is only important thing is relaxant due to your acidosis. Use a neuromuscular monitor for recovery, and renal transplant patients generally don't require more of a ICU care, whereas a barrier care is to be taken. They are isolated from other patients, and a single care technique is being given. Post-operative management, aphakic extubation, warm and well perfused patient, supplement oxidation, fluid intake based on the previous urine output plus 50 to 100 ml per hour, initial 6 hours 100, then go by urine output plus 50. Then once the patient is throwing good urine, you are not bothered. Adequate analgesia and good high dependency care unit. So immediate post-op care is delayed recovery, hypertension, perioperative MI due to stress in a cardiac compromise, inadequate graft function, pulmonary edema due to the volume status which you have given a trial volume challenge, and post-op nausea emitting which is aggravated in CKD. Post-operative pain management can be done by your IV anesthetic agents, IV narcotics. Fentanyl is the drug of choice. Avoid morphine. Epidural can be given, and other school of thought says epidural is going to be a source of infection. Avoid epidural also. You can use a combination of fentanyl and paracetamol. Role of regional anesthesia. Initially, when we started with the advent of newer agents, this has been not the technique of choice. Risk of epidural hematoma due to anticoagulation. Now, epidural is not preferred. Complication of transplant delayed is rejection, infection, cardiovascular compromise due to volume variability, recurrence of the disease in a grant of acute rejection, corticosteroid-related complications also. So summary is good knowledge about the CKD, a good pre-op history and assessment of the clinical condition, good pre-op evaluation, good preparation, good pre-op planning, good plane of anesthesia, good recovery, good post-op care, good post-op pain relief, and less morbidity will be the content. So this is the topic which I deal in this order, and this thing will be in a good status. I thank my team for helping me in this thing. Thank you very much.